A warm good afternoon to everyone present here and for everyone who's joined us online today on a beautiful Friday afternoon here in New Delhi. I am Megha, the National Sales Head with Cepheid India Private Limited, and I will be your host for the day today. We'll be really doing a session on diagnostic and management of tuberculosis. Tuberculosis, known as TB in short, remains a significant global challenge, causing millions of infection and deaths annually. Despite advances in diagnostics and treatment, gaps in early detection and antimicrobial resistance continues to hinder efforts to eradicate TB. To mark this occasion of World TB Day 2025, Voice of Healthcare, in partnership with Cepheid and Max Healthcare, welcome you to the hybrid program to raise awareness, promote the latest advancements in TB diagnostics, and facilitate discussions amongst clinicians and diagnostics experts. To kickstart this event, may I please request all the speakers and dignitaries to join us on stage to lamp the light and create a light path to eradicate TB. May I please request Dr. Pranav, MS Max Hospital, Dr. Poonam Das, please join us on stage to light the lamp, Dr. Bansidhar, Dr. Vivek Nandia, Dr. Sandeep Nair, Dr. Jay Kumar, and Dheeraj Sood to please join us on stage to light the lamp. Dr. Jaya.
आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय श्रीपज्योतिर्जनार्दनः श्रीपज्योतिर्परब्रह्म श्रीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तुते ज्योतिर्ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ज्योतिर्ब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः आरोग्यं देहि पुत्रां च प्रतिगच्छामि मे सदा जवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् जवेरस्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य दृष्टे गृहे दीपः तस्य नास्ति दरिद्रता शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you for this auspicious start. On this note, I would request Dr. Poonam Das, Principal Director, Max Lab and Blood Bank Services, to kickstart the meeting and to welcome the gathering here today.
Good morning, everybody. On behalf of Max Healthcare, I heartily welcome all of you to today's CME. Well, the topic is very old. It's tuberculosis, and I think all of us, either 20, 30 years older than me in medical colleges, or me or the younger ones, everybody's been studying tuberculosis, and it's sad that we still have it all over the world. Um, I think it was the bacilli was, if I'm not mistaken, I was just reading about it. It was invented in 1882, if I'm not mistaken. So imagine how bad the bacilli is, how it's a tough one, and we have not been able to eradicate as yet. But the good part is that there's just so at least in the past 20 years, there's so many diagnostic tools which have come up, which help in early diagnosis, and thus the physicians can start the medicines earlier. I remember in the medical college there was nothing but a AFB stain and TB culture, and then one had to wait for more than a month for the bug to come out positive, and then to put the first line and the second line of drugs and see the sensitivity. By then the patients, it would be so florid, it would be all over. And I distinctly remember in our while I was doing pathology MD, our microbiology professor used to say that this AFB is more dangerous than actually the HIV virus, because apparently HIV virus is pretty fragile. So once out of the system, out, it just dies. But AFB doesn't. So he used to tell a tale saying that even when you fix the slide, you stain it to see AFB, it's still alive. I mean, of course, it's not alive, but just exaggeration to prove the point that it's a terrible bacilli. Doesn't go on its own, doesn't die on its own, multiplies. And earlier it was in lungs. Now, any place, any organ, it's just everywhere. There's a national tuberculosis elimination program which is run by the government, and they've pledged to eliminate tuberculosis in 2025. I think the global target is 20, by 2030, but in our country they say 2025. In fact, we just got accredited by them for the proficiency testing. So I think we're one of the very few non-government hospitals which have got that accreditation. We have a very beautiful in-house high-end BSL-3 lab, and we have end-to-end equipment. So we have everything. We have MGIT, we have AFB culture, we have sequencing, we have gene expert, quantiferon gold. We have entire set of tuberculosis testing in-house, and now you get the test results, say, within the same day. We get to know within 2 to 3 hours, and then we put up the first line drug sensitivity, and the physicians get to know, say, within 24 hours. So, in fact, we are, where tuberculosis is concerned, we are also accredited by the CDC, and we are the only lab which does tuberculosis for immigration in entire North India. So besides NABL, we have a CDC accreditation as well. And now we've lately acquired the accreditation, or said that we passed the proficiency testing by the National Tuberculosis and Elimination Program by the government. So we'll kickstart today's CME, and I'm sure there'll be lots and lots of questions. And I hope you enjoy, and I hope it's a very fruitful discussion. So enjoy your day today. Thank you.
Thank you, Dr. Poondas. With this, I invite Mr. Dheeraj Sood, General Manager, Cepheid South Asia, to share his Sefid's commitment on TB.
Thank you, Mega. And good morning, good afternoon, everybody uh, in the room and all of the other important stakeholders who are joining us online. Uh, Thank you, Dr. Punam Das and Dr. Bansidhar, for helping us arrange this fantastic gathering and event today. I would like to take a couple of points which Dr. Punam Das has shared in terms of tuberculosis. And we all will agree that this disease go back to 1800s and 1900s when many of us were not even there, right? And this is the infections or infectious disease which is bothering the entire global community. But it becomes more important for all of us because the majority of the burden of tuberculosis is in India, and we all know about that. Having such events, speaking about tuberculosis, the diagnosis, early diagnosis, treatments, uh, become a necessity for all of us to remind each one of these stakeholders that we are in this fight together. Um, why? There are two things which comes to my mind because we have been working in this space as Cepheid, as gene expert for almost a couple of decades now. Is two things. One is the awareness, both at the patient level and at the clinician level. And second, the early diagnosis and correct diagnosis of the infection, which helps the clinicians to start a prescription which is effective and which is correct, so that the disease doesn't spread across the other people who are coming in contact with the infected persons. With that, I think Cepheid has been committed to this eradication program for almost last 2 decades. We have been partnering with National TB Elimination Program for last over 10 to 12 months with a gold standard gene expert platform. And we also know that almost around uh, more than 6.8 million tests were done in 2023 in India, both on public and private platforms. And I'm happy to share that out of that, 20% and higher notifications were done in Gene Expert. Not even that, when the TB goes beyond into multi-drug resistant kind of a tuberculosis, where you need different prescriptions, different medicines, our test, which is XDR, helps you to define the second line treatment. So that is our commitment in terms of providing the gold standard technology to clinicians and to patients. Second, we do understand the need of access to each and every patient in India, and that's the reason we have started our manufacturing in India for the TB cartridges, especially in 2022. We are also exporting from this manufacturing unit to other countries like Sri Lanka, Bangladesh, and also certain countries in Southeast Asia where the density of this disease is in a high burden. So that's a commitment towards India. Once again, it is an honor to be among such a honorary gathering, August gathering, in the house and on the line. And I look forward to all the speakers who are speaking about TB and early diagnosis, along with certain kind of tests which are available from Gene Expert. Thank you once again. I look forward to a great discussion. Thanks a lot.
Thank you, Dheeraj, for reiterating the commitment from Sefid for on this disease segment and specifically about Make in India and the number of tests that are done there on the Gene Expert platform. With this, I would like to invite Dr. Bansidhar Tarai, Principal Consultant and Head Microbiology and Infection Control, Max Super Speciality Hospital, MD in Medical Microbiology from PGIMER. Dr. Tarai is an active member of Infection Control team and leads all the AMR activities here in this hospital. So we request you to talk about the TB commitment in Max, followed by your session on this today. Presentation is here.
Right. Next slide. So, ma'am, and today we have gathered because we have a World TB Day that is on 24th March. So, for that, this week we have selected this CME, and this is a PanMax event. And like our commitment is very clear on Max Healthcare commitment on TB is that we will be the best in diagnostic on TB. We have a complete range of TB diagnostics, and as a microbiologist, I always my dream is that whenever any new equipments or new diagnostic setup come, I usually first put in Max Saket. And Dr. Poonam Das is always supportive to me in all this, like even nanopore sequencing in India, we are the first to put here. Even Gene Expert XDR, when it comes to India, we first put here. In Gene Expert MDR, we took little bit time because of commercial issue, but XDR we are first put in India. So we have a complete range of tests, and we are the BSL3 lab which we built at that time. I think 2010. It's cost around 35 lakhs, and Dr. Ma'am has always supported on this. We have put hands at that time, and then Gene Expert. In 2017 and 18, two panel experts from CDC came and they have approved our lab for all immigrations, US, then Australia, UK, New Zealand, Canada. And we recently got the RNTCB approval from government of healthcare, like for TB culture and sensitivity. Usually government lab are approved by RNTCB, but private setup is little bit difficult. They also audited twice, one pre and final audit, and they do a parallel 100 cultures screening both here, and one set will be tested at government, and we qualified for that, and they have approved our result. And we have also filed as a request for gene export, both MDR and XDR, that is from the ministry from Bangalore. And we have all the machines available. So what we have all tests also available for our clinicians to satisfy. This is the certificate we got recently got from the government of India. That is our NTCP. And this is the complete list of tests which we are doing. We don't have anything left for TB. And turnaround time, test code, everything is mentioned here. And we have almost more than 1 lakh tests we are doing. All the AB stain cultures so we have gathered annually. We do more than 1 lakh tests on TB. So this is our commitment to. We are the first to do all the tests, and we should not have not only TB, all the microbiological tests or even lab tests. We usually first to do the test. Now coming to our presentations on the topic. So if you see, this is the data in 2023 Government of India. So more than 24 lakhs TB cases, and there are 69,000 estimated incidents of drug resistance. So our theme this time is basically we are being focused on drug resistant tuberculosis. 11,000 are resistant to fluoroquinolone. So now fluoroquinolone resistance has gone up. That's why we are not using fluoroquinolones in routine antibiotic, patient routine antibiotic. We are preserved for the TB test. 23,000 resistant to mono-resistant INH, and 90% of whom are people started second line treatment. So coming to the why reverse the TB diagnosis has revolutionized after the coming of Gene Expert in 2019 when Gene Expert came to India. Actually, it is a game changer in TB. That's why government is thinking more. We can have chance to eliminate this because the diagnostic has gone to a deeper level. District level, they have started doing the NTA and NAT testing. So now it is much easier. Initially, the AB strain was being done. So NAT is now in the front side of TB and in all the programs in the National TB Report 2014 also.
approximately 19 million smear microscopy, but only 6.8 million NAT testing. So they want to increase the NAT testing so that the drug sensitivity as a diagnosis in the initially you will get in 24 hours. And now we have to discuss in the panel. Dr. Sandeep is there, Dr. Jaya and Dr. Birknay. They will give their feedback how we report in our turnaround time. So why Gene Expert Ultra? So we are doing the Gene Expert that is only targeting the RPOB gene. But when the Ultra came, we immediately switched. So we are not doing the normal Gene Expert. In every Gene Expert we are doing only the Ultra. It's because the target has increased. Target from RPOB to IS 1081 and IS 6110. So there are three targets. So we will not able to miss any TB cases. Even the detection level is 12 CFU per sputum. So if 12 bacilli is there, our Gene Expert will detect. We are not doing the previous Gene Expert where we are only kept one code, that is Gene Expert Ultra. And everybody has to request on this. This is a WHO endorse and Government of India is also endorsing nowadays. And the turnaround time, the processing time is 77 minutes, but we usually give in the same day because you sample coming here and processing, then reporting. And if many samples are come, so we have three Gene Expert and 12 modules. So we have given same day reporting on Gene Expert. And those samples are coming for AB culture, we process AB cultures, and from centrifuge samples, we do the Gene Expert. So isoniazid monoresistance tuberculosis, this is the one of the major concerns. So here isoniazid resistance is a major chunk of drug resistance tuberculosis. That's why with majority of the patients detected with the primary monoresistance, is strengthening on this monoresistance TB, we have now started doing the Gene Expert XDR. So here, Gene Expert MDR and XDR. This is basically a game changer. Okay. So this is a game changer and detecting the drug resistance TB. And from the day one or day two, you will get all the drug sensitivity of MDR and XDR TB. And basically, what there is a three things. The mainly whenever we get any respiratory samples or other samples, mainly respiratory. Government of India is mainly focusing on respiratory samples. Whenever the MTB is positive, either rifampicin sensitive or resistance, we advise we should do the same sample immediately, the Gene Expert XDR, so that you will know all the second line drugs from the beginning itself. Otherwise, then it is difficult to trace the sample after this. So then Gene Expert MTB and XDR can detect low and high levels of mutation associated with CAG and INH. If you see the WHO, now Dr. Jaya is asking the Government of India guidelines XDR, if you have incorporated or not. This is the WHO. WHO is very clear on this. In adults with bacteriological confirmed pulmonary TB, the Gene Expert MTB XDR may be used in sputum for the initial detection of resistance to isoniazid and fluoroquinolones. This is normal TB cases. In adults, if there is resistance, TB and resistance to rifampicin, it is 100% means MD XDR to be used in sputum in the initial detections. And in adults with the bacteriological confirmed pulmonary TB and resistance to rifampicin, Gene Expert MTB they are used to sputum and initial detection level. So initially, what I'll say is that MTB rifampicin sensitive or resistance. From the beginning, both the MDR and XDR should be tested, and one AB culture preferably. So WHO recommend export MDR and XDR as a low complexity automated NAT for the detection of resistance to isoniazid and second line IPTB. So these are the treatment guidelines, and here you can see in August 2024, the National Tuberculosis Elimination Program also recommended introduction of CBNAT, MTB, and XDR tests for rapid molecular detection to resistance to NH, fluoroquinolone, second lines, and for a laboratory. So these are the NTIP guidelines where Gene Expert, MDR, and XDR has been incorporated. So the impact of reflex MTB and XDR. So if you see MTB detected rifampicin susceptible or MTB detected rifampicin resistance, both the groups should be gone as a reflex testing for XDR-TB. If you MTB negative, then the gene export will also come negative. XDR gene export will come negative. So we all know what is the problem in diagnostic delay. If the patient's delayed diagnosis, AB culture takes time, and the drug sensitivity is also taking time. So if the initial, if you know what is the MTB and the drug sensitivity by ultra gene expert or MTB XDR, then the workflow from the beginning itself is easy. Otherwise, many patients we have seen, Dr. Sandeep Nair will also, Dr. Vivek Nangi and Dr. Jaya will tell you about the story. It's very difficult at the end when the patient is not able to complete the course. It's because of drug sensitivity testing is not been done initially. After that, whatever we do is very difficult. So my take-home message is based on the NTAP recommendation, the NAT testing should be prioritized, and WHO also endorses the NAT testing and the NTP approved TB diagnosis. Monoresistance INH is a problem, and we need to holistically use this diagnostic testing before treatment. MTB and HDR reflex or MTB rifampicin alter can be a potential impact in the same day testing. So yes, we can and NTB commit, invest, and deliver. So that is our main thing. Thank you. I think question answer we can discuss at the end.
Thank you, Dr. Bansidhar, for taking us through the importance and the need for faster and accurate diagnosis in TB today. With this, I now invite Dr. Vivek Nangia, Vice Chairman and Head Pulmonology at Max Hospital. Dr. Vivek is an internationally renowned interventional pulmonologist with over 2 decades of clinical experience. Has undergone extensive training in multiple fields of pulmonary and critical care medicine. Dr. Vivek will talk to us about the management of DRTB and the importance of this. Thank you.
Thank you so much for those kind words of introduction. At the outset, I'd like to congratulate Dr. Bansi and Dr. Poonam for holding this very great session this morning when we're just round the corner for the World Tuberculosis Day. In fact, we as clinicians should have actually taken the initiative, but we're grateful to them for having taken this initiative and holding it here. TB is still continuing to be a rampant disease, not only in our country, but globally. And one of the main reasons why it cannot be eradicated or eliminated from the surface of the earth is because of the multi-drug resistance that this bacteria has acquired. As Dr. Poonam was also mentioning that this bacteria has been there for probably a couple of centuries now, and yet we are struggling with it day in and day out. If you look at the statistics, then drug-resistant tuberculosis remains a major global health threat. An estimated 450,000 new cases of rifampicin-resistant tuberculosis were reported in 2021. In India alone, 2023, the case notification has gone up to 179 cases per lakh of population and about 64,000 cases of MDR-TB. Globally, drug-resistant TB treatment success rates have now increased from 50% in 2012 to 60% in 2019. And now, with the more evolved diagnostics that are available to us, we expect to detect them early and treat them early and more effectively. Yet, 15% of the patients with MDR-TB are still dying from this disease. This is just a graphic to show the degree of drug resistance that exists in the entire globe. Dr. Bansi has already spoken about the various investigations that we subject our patients to. Of course, it's a routine for us in the OPD that the moment you suspect anybody, even on an X-ray, if you're suspecting a tuberculosis, you would not treat it without getting a sputum sample tested. In fact, there are patients who we get in our OPDs with, say, a mass where they've done a CD carrier biopsy and that is showing necrotizing granulomas, but we don't stop there. We would still send a sputum sample. If not a sputum sample, a bronchoscopic lavage. Why? Because it has become very important to have a microbiologically confirmed diagnosis because the degree of MDR is so high, you wouldn't want to treat somebody with first line drugs for almost 2 months, and then 2 months later realize, oh, this is all drug resistant. So it is very important to get to a confirmed diagnosis before you start the treatment. We are no longer in that era where you can start somebody on an empirical treatment, because all these drugs also have so many side effects. Therefore, you must send a sample and get the patient investigated thoroughly before you start the treatment. You won't lose anything if you start the treatment 2 days later or 3 days later, unless it's a critically ill ICU patient or something of that sort. So, Zeal-Nelson staining is something that we still rely on. It's widely available, cost effective, and reliable for high burden cases. Fluorescence staining is being done still in some centers though, and cultures, of course, we know take a lot of time. Yet we send a culture sample for all our patients, because just in case it turns out to be positive, you are able to get a sensitivity pattern also subsequently. But of course, the turnaround time is slow; it's about 4 to 8 weeks, and there's always a risk of contamination, and it turns out to be expensive. Therefore, we rely more on these molecular genetics now, the CBNAT and the other tests. So these are all cartridge-based tests, whether you use GeneXpert or TrueNat. I think we are very familiar with GeneXpert, and GeneXpert is superior to TrueNat in many ways. And this is what we've been using so far. Earlier, we would use GeneXpert. Now we use GeneXpert Ultra, which has a higher sensitivity and requires lesser number of bacilli in the sample to be detected. And then GeneXpert MTB XDR. So we, as in our department, in our unit, have made it a policy that anybody who's GeneXpert positive, we do check for GeneXpert XDR also. Because when you have GeneXpert positive, that will only give you a rifampicin sensitivity, but the XDR panel would give you sensitivity to the other antitubercular medications as well. So it's like a routine for us to be doing that now. It has many advantages: quick detection, shorter turnaround time, high sensitivity and specificity, and then simultaneously you can get a drug resistance pattern as well. Just the same way that even for our routine sputum samples and bronchoalveolar lavages and all other cultures, we started relying more on the genetics, we rely more here also on the molecular diagnostics. Expert Ultra and Expert XDR. XDR would give you sensitivity against fluoroquinolones, the kanamycins, the capromycins, and also INH. INH is the most important, and that is, as Dr. Bansi was also stating, that that's the most common resistance to get, and that would alter your line of treatment also. So that is very important to check whether the patient does have INH resistance or not. Then, of course, we have the Haynes test, that is the line probe assay test, where you can get INH and rifampicin resistance seen in the same setting. It's again a rapid diagnostic useful for detection of MDR as well as XDR, and it distinguishes between high level or low level drug resistance also. But the major disadvantages is the number of drug readabouts are low, and fluoroquinolone sensitivity is only about 80% in the smear negative samples. So LPA1 will give you the sensitivity for rifampicin and INH, and LPA2 would cover the fluoroquinolones, the aminoglycosides, and the ethionamide as well. And the various gene patterns would be available to you in no time at all. Then we move on to the next generation testing, which includes the NGS, the WGS, that is the whole genome sequencing. So we've actually reached a stage where we can completely identify the genomic structure of the AFB and the various gene patterns. All the drug resistance, all the drug patterns can be easily identified, and your treatment be tailored accordingly. This is still more of a research tool, but we are doing it here in our organization, but is not relevant, not being performed clinically across the globe yet. So ultimately, it's a combination of phenotypic and genotypic approach that is required for optimal diagnosis of tuberculosis, which is drug resistant. So we need to revise our definitions, where we have INH resistance, that's a monodrug resistant. Then you have MDR resistance, where rifampicin and INH resistance is present. Pre-extensive, pre-XDR, as we call it, is a TB strain which is resistant to rifampicin, INH, and also to fluoroquinolone. Then you have the polydrug resistance, where it may be to ethambutol, pyrazinamide, or any other drug apart from INH and rifampicin. Rifampicin resistant is considered to be MDR only, because if it is rifampicin resistant, you presume it would be INH resistant as well. And then, of course, you have XDR resistance, where it is MDR plus resistance to fluoroquinolone and at least one of the additional group A drugs, which I'll just come to in the subsequent slides. Now, there are newer treatment trials which have actually completely changed our approach to all these patients with MDR tuberculosis, where earlier we used to have an 18 to 24 months long ATT regimes. Now we have much shorter regimes, as short as 6 months regime for even your MDR and XDR or pre-XDR patients. The next trial actually showed us that three drugs, bedaquiline, pretomanid, and linezolid, has collectively shown its 90% treatment success rates in patients with pre-XDR and MDR TB with treatment intolerance or non-response, which is comparable to the standard treatment regime. In one of the regime, they actually tried 1200 mg of linezolid, and there in that group they found the peripheral neuropathy to be much higher and myelosuppression also to be much higher as compared to the 600 mg group. Then you have the TB practical trial and the Xenix trials, which recommend that linezolid 600 mg is good enough to be used in this regime of BPAL, is what they call it as a short form. The TB practical trial also recommends that the 6 months regime of BPAL-M, that means bedaquiline, protomanid, linezolid, and moxifloxacin can also be combined together and given with a favorable efficacy of about 88% success rate and a fairly good safety where 600 mg of linezolid is being used. Evidence has largely revealed that optimal dosing of linezolid 600 mg is more or less sufficient and it is safe even in ladies who are pregnant. So the three regimes that have now evolved are: first regime that you should be trying in your patients with MDR or subjecting your patient on MDR is the BPAL-M. This is in patients with 14 years or more. It could be ranging from 6 months to 9 months, 26 weeks to 39 weeks. Then the second regime, the second alternative, if somebody does not tolerate the BPAL-M, is not eligible for it, and we'll just come to the eligibility criteria, is a 9-month shorter oral MDR regime. And if somebody is found ineligible for both of these, then you have the usual longer oral MDR regime. That also has changed and is now based on the DSC pattern. All patients must be subjected to a thorough preclinical evaluation, which includes the history, the physical examination, previous history of ATT, especially if the patient has taken bedaquiline and the protomanid and delamanid or not, or linezolid, a thorough clinical examination, the nutritional status, neurological examination, OFPAL, visual acuity, blood sugar, HIV status, complete blood counts, LFT, RFT, electrolytes, urine pregnancy test, chest X-ray, ECG. Now, BPAL-M regime, the major inclusion criteria would be anybody above 14 years of age, probable MDR or confirmed MDR TB patients with exposure to any of these three drugs should be less than 1 month, if at all there has been some exposure. The QD interval should be less than 450 milliseconds, and it should be a non-lactating woman, lactating woman but not breastfeeding, non-pregnant or pregnant women with less than 20 or less than 24 weeks who agree to get the child terminated. So these are the criteria. The exclusion criteria are the usual. If somebody has deranged LFTs, deranged KFTs, deranged cardiac functions, a prolonged QT interval already, severe forms of extrapulmonary MDR TB, in these situations, you would avoid using this BPAL-M regime. Hypokalemia, hypomagnesemia, hypocalcemia should be corrected prior to the patient receiving any of these drugs. So in BPAL regime, you give them bedaquiline, 400 milligram once daily for 2 weeks, then 200 milligram 3 times per week, or 200 milligrams daily for 8 weeks, and then 100 milligram daily. So these are the two regimes for bedaquiline. Protomanid is a 200 milligram tablet, which is given as once daily. Linezolid 600 mg once a day, moxifloxacin 400 mg once a day. Along with that, you would add pyridoxine, basically to take care of the peripheral neuropathy that linezolid can cause. These drugs are usually administered orally with food. We avoid milk and milk containing products, calcium supplements, or calcium containing antacids before and after 2 hours, and adequate water intake should be ensured. The standard dosage, there is no weight bands that are required for this. The relative contraindications for BPAL, I have already discussed, are the same, basically deranged LFTs, KFTs, patients with cardiac issues, severe neuropathies, you would avoid using the BPAL regime in them. The BPAL regime also provides you some degree of flexibility with the dosages. If moxifloxacin alone is discontinued, you can still continue with BPAL. If the dose of linezolid has to be reduced, it can be reduced to 300 mg after the first 9 weeks. If linezolid is discontinued in the last 8 weeks, even then you consider the regime to be completed. And the duration extension from 6 to 9 months is basically if the culture is positive, even between 4 to 6 months. So as I said, it's 29 weeks to 39 weeks, 26 weeks to 39 weeks of regime, and then the usual follow-up of routine cultures and smears that need to be tested in the third and the fourth month. Then you have the 9-month shorter oral MDR regime for those patients who are not tolerant or not being able to give BPAL-M, provided that the disease is not extensive, not a severe form of extrapulmonary tuberculosis. Again, the lactation and pregnancy criteria remains the same. In this case, what we do is we give them 2 months of linezolid with 4 to 6 months of leoflox, clofazimine, pyrazinamide, INH, and ethambutol, and bedaquiline along with it for 6 months, extendable to 9 months. If you don't want to use linezolid or there's a contraindication to use linezolid, then instead of 2 months of linezolid, you substitute it with 4 months of ethionamide. So if sputum remains positive at month 4 also, then the initial phase is extended to 6 months. If ethionamide and high dose INH can be dropped after the initial phase, depending on the smear status. And bedaquiline can also be extended to 9 months if required. So how do you choose between ethionamide regime or a linezolid variant? That if somebody has optic neuritis, peripheral neuropathy, hemoglobin or neutrophils are low or platelets are low, there's a myelosuppression evidence, then you would choose ethionamide variant. If you consider the pill burden, then of course you would consider linezolid because it's only for 2 months and just 1 tablet once a day. And in pregnancy and lactation, again, linezolid is a safer drug to be used. These are the dosages that you use for these drugs. Now, what factors need to be considered when you have to modify the 9-month regime? Bedaquiline can be extended from 6 to 9 months, as I said. Prothionamide can be used instead of ethionamide. Moxifloxacin may be used monitoring the cardiac functions. If full dose of 600 mg is not tolerated for the first full 2 months, then you can reduce the dose or change the regime. In case of intolerance to pyrazinamide or ethambutol, one of them can be dropped during the continuation phase without switching to a new regime. If bedaquiline, leofloxacin, moxiflox, linezolid, ethionamide, or clofazimine are stopped early, then we need to switch to a new regime. Then finally, the third regime is the longer oral MDR or the XDR-TV regime, which has bedaquiline plus levoflox, linezolid, clofazimine, and cycloserine, which is continued for 18 to 20 months, with bedaquiline being a part of it for the first 6 to 9 months. For those who cannot be initiated on either of the previous regimes, you would consider this. After month 6 of treatment, the patient must be reviewed based on the month 5 culture results. If month 5 culture result is not available in the end of 6 months, then taper the dose of linezolid to 300 mg will be based on month 4 culture result. If the month 5 or 4 culture results remains positive, then the dose of linezolid has to continue at 600 mg and the regime has to be extended by 1 more month in the initial phase. The grouping of the drugs has also got changed now. The group A comprises levoflox or moxiflox, bedaquiline, and linezolid. Group B comprises clofazimine, cycloserine, or teredosin. And group C are all the remaining drugs. The ethambutol, the delamanide, pyrazinamide, imipenem-cilastatin, amikacin, streptomycin, all of these drugs are in group C now. So when you're formulating a longer oral regime, the treatment regime should consist of at least 4 drugs that are likely to be active based on the sensitivity pattern. All 3 group A agents should be used, plus 1 from group B, like clofazimine and cycloserine, should be used. If only 1 out of the 2 group A agents are used, then both group B drugs should be included. If the regime cannot be composed with agents from groups A and B alone, then group C agents are added to complete it. The treatment regime should be modified if the results from phenotypic DST are available. Kanamycin and capromycin are not included, so we have to stop using them now. So we only restrict ourselves to amikacin and streptomycin. The treatment regime should be administered for 18 to 20 months, and close monitoring of adverse events is mandatory. We do not include paracetamol or ethambutol in the regime unless proven by drug susceptibility testing. We do not include clothramide or ethinomide in the initial regime if molecular drug susceptibility testing shows a mutation in the promoter of the INHA gene. In low-level resistance, the agent should not be counted amongst the active drugs in the regime. So the emerging global evidence suggests that the 6 months BPAL regime and BPAL-M are cost-effective and improve compliance and clinical outcomes in drug-resistant patients. In HIV patients who are on antiretroviral therapy should be initiated as soon as the tuberculosis treatment is tolerated and ideally within the first 8 weeks. Bedaquiline is well tolerated, safe and efficacious in these patients, but should not be used with efavirenz, and use with lopinavir-ritonavir requires careful monitoring. Dolutegravir, delaminide might be better tolerated. Large pill burden and frequent drug toxicity need to be monitored for. And HIV-associated MDR tuberculosis often have advanced TB disease and increased risk of the iris and drug interaction and toxicity if ARV is initiated. So this is the chart that we follow for all our patients, the algorithm that we follow. Whenever you're suspecting tuberculosis, send it all for TB diagnostic. If it is MTB sensitive, positive and rifampicin sensitive, then we continue with the standard 2-HRZE/4 HRE regime. If it is INH resistant, then we substitute the H component with the levoflox and extend the treatment by 1 or 2 months. If you're not able to use levofloxacin, then maybe you could try linezolid in this situation, but you would continue with these 4 drugs throughout the period. If MTB is rifampicin resistant, then you get the XDR done. If XDR is showing INH resistance, even if it is not yet, you would want to continue with a BPAL-M regime. If that is not tolerated, then the second regime, the shorter oral chemotherapy, and then finally the longer oral one if somebody is not able to tolerate it. So this is again the same version, the same format, it's the same regime approach in just a different format, where in patients with more than 14 years of age, BPAL-M regime is the most preferred, followed by the 9-month regime. If not, then the longer oral regime. These are the 3 main articles from which I have taken this today's talk. So in case anybody wants, you can access these. These are easily available online. Thank you so much for a very patient hearing, and thank you for inviting me here today.
Thank you, sir, for a detailed presentation and explanation on the diagnostic tests and the treatment methods followed in India today. May I please request Dheeraj to present a token of appreciation to Dr. Vivek Naik. May I request the team who's helping us with logistics to please put up the chairs on stage. We now move on to our very exciting panel discussion session on diagnosis and management of DRTB. So again, the logistics team, if we have mics, if we can have this one. Okay. Introducing our eminent panelists today, Dr. Bansidhar Sarai again, Director and HOD Microbiology. Dr. Jaya Kumar, Principal Consultant Pulmonology, Max Saket. Dr. Sandeep Nair, Principal Director and HOD Pulmonology, Max BLK. Dr. Saraj Joshi, Director and HOD Pediatric Pulmonology, Max Vaishali, who has joined us online, and Dr. Manish Garg, Associate Director and Head Unit Pulmonary Critical Care and Sleep Medicine, Max Dwarka. May I request you all to join us on stage? And the panel discussion will be moderated by Dr. Swati Tripathi, Director Clinical Solutions, Cepheid. May I please request the panelists to join us on stage? Dr. Sharad Joshi, I hope you can hear us clear online.
Will modify. Right? Right? Thank you so much for this opportunity, Dr. Bansi, Dr. Poonam. And already, Dr. Nangiyar's lecture was so clear, so enlightening. We probably will have some pointers which are coming from the same presentation or something which Dr. Bansi already has presented. But it will be a good idea to probably reiterate all those messaging again. So I'll. Is Dr. Sharad here online? Is there? Okay. Great. So, Dr. Sharad, can we start with you? Are you able to hear us, sir? Okay. Oh, okay. So then, Dr. Sandeep will actually, sort of ask two questions in one from you. Um, so, one is very quickly, your views on rapid diagnostics. Um, and that is the context is actually because the TB is like what we have been discussing that 1882, the bacilli was identified by Dr. Koch, and it's actually otherwise been present, I think, in from 3,000 years or more is what we read. Diagnosis has been multiple types. Uh, okay, so Dr. Sharad is here. Sir, sir, are we audible to you? Now, I think we are audible to sir. Yes. So, Dr. Sharad, then we will start with you on your views, for the role of rapid and accurate diagnostics, which is basically the TB treatment is changing in its algorithm. The paradigm is changing basis the diagnostics. So your views on the role of rapid and accurate diagnostics.
Early diagnosis a gross difference in the management, especially in a disease where the management is going to be more than 6 months or 8 months or 9 months because TB can affect any of the organs from head to toe. It can be brain TB, it can be laryngeal TB, it can be TB of eyes or it can be TB of skin. So even in 21st century, diagnosing tuberculosis is one of the most difficult tasks. So it makes sense that if we can fetch the diagnosis earlier, that makes a lot. I remember one of my cases where, hello,
Yes, we can hear you.
yeah, yeah. So I remember one of my case where already 20 plus tests had been done. Patient had undergone already CT chest, CT abdomen, and fever was ongoing, and there was no diagnosis established. And finally, we had to do a bone marrow biopsy, which showed AFB positive results. So for such a enigmatic disease, if there are tests which gives us rapid diagnosis, it is very important that it will help manage these complicated cases, identify early and manage them early. Tests like Gene Expert or CBNAT, these are few tests which actually has changed the complete paradigm of management of tuberculosis. And previously, when empirical treatments were given, then there were a lot of misdiagnosis. So obviously, even till today, we need a definitive and rapid test for diagnosing tuberculosis because in extrapulmonary tuberculosis it becomes very difficult. In pulmonary tuberculosis, it is fine that you have subjected the patient for a sputum examination. Even the sputum sample should be sent for CBNAT. But for extrapulmonary tuberculosis, patching up the tissue and sending it for diagnosis and getting the rapid diagnosis is most important because otherwise the disease is going to progress as well as the complications will increase.
Right, and thank you so much for this complete clarity. And Dr. Sandeep, let me come to you for this. We were looking at Dr. Bansi's presentation where INH monoresistance is increasing, and even Dr. Nangya alluded to that. Currently, how are you managing those cases? And let's say if there it was a possibility that you are getting INH information same day, how will it change the patient management?
Yeah. So before I answer your question, can I just take a clue from what my fellow colleagues said on the
Right.
same thing? See, we come a long way. A time when we were depending only on the LJ medium for 6 weeks, and then another 6 weeks to the resistance. So 12 weeks gone for the patient to start medication. And we have gone a long way now. Within a day, we come to know what exactly it is, and the things have really changed. Unfortunately, still we are not able to control the tuberculosis. It's still going rampant, and MDR is increasing. INH monoresistance is the highest among all the drugs, and it's always a challenge when the patient comes to us and the patient first to diagnose them and then to treat them. If they turn out to be resistant to any drug, then it's always a challenge for us to treat it. What we are doing it is because thanks to newer diagnostic tests, we can come to know INH disease in a day, within a day or within an hour that yes, this patient could be a INH disease distance. So frankly, we just substitute with levofloxacin and we continue the rifampicin, we continue pyrazinamide, we continue ethambutol, but we give it for say 6 months. There's no IP or CP, there's no intensive phase or continuous phase. We continue all the four drugs to these patients. However, if the patient is not able to tolerate quinolone or is not able to tolerate some pyrazinamide, then we may substitute with the linezolid in these patients. Or even that is not there if the patient not tolerate, then of course clofazimine or the reserve drugs can be given to these patients. And mainly ethanamide or clofazimine may be given to these patients. But normally we are starting with levofloxacin, INH, pyrazinamide, ethambutol. We continue for 6 months. And in case they are still positive after 4 months, we may continue for 9 months in these patients. And if the patient is still not responding, then it may be a rifampicin resistance also, which we were not able to diagnose it. The probable rifampicin resistance of these patients, we may classify it and treat it as per the MDR or the.
Right, sir. And in fact, this is I really appreciate Dr. Bansi's point when he was making his presentation that whether the case is rifampicin sensitive or resistant, you are reflexing it for looking at INH, which is important. And of course, we will come in due course of discussion to fluoroquinolones as well, because you are mentioning that levofloxacin is being added to these cases. But my next question, I'll go to Dr. Bansi, is and so there are too many variables actually when you are selecting which testing to be done, and multiple. I think the testing already is being done, and patient is sort of following an algorithm. Question is, what are those aspects that you are looking at when you are selecting the technology for testing?
The more so you TB, we need to have multiple tests. That is one concern. Second is that the test we usually require, which is more rapid, can give a turnaround time in the same day or maybe 24 to 48 hours. That is the one thing. But AB culture we have to do because sometimes then for the sensitivity purpose, so AB culture and gene expert from the beginning itself we want to do because it will give a the management direction where it is MDR or HDR TB. So those one who has a very good sensitivity, specificity, and good quality, which is recommended by WHO or the national NTTB programs, that we also take into account. And AB culture still we are keeping, but we will take input from clinicians, but gene expert AB stain as a routine also. All things are categorically C and main is the turnaround time.
Right.
Drug sensitivity in within 24 hours, if it is we are getting, then that is the best.
Right. And of course, I mean, any which way that the sample is being sent for culture and, for further any or any possibility of NTM, etc. So that's the Dr. The and thank you so much. I understand that you actually really braved the traffic to reach here. So thank you so much for that. We've been discussing about these undiagnosed case or missed case. Although a lot of efforts are going on by NTEP also in terms of active case finding and to bridge that gap. Um, but still, I mean, globally there are quite few which we call as missing millions. What is that bigger risk that you see which is associated with from both healthcare perspective and community level with these undiagnosed or misdiagnosed cases?
Good afternoon, everyone, and I'm sorry to be late. See, tuberculosis is a very common healthcare problem in our society, and it's India being the most is the only country with the maximum number of the tuberculosis patients, and with our low socioeconomic and low educational status of general population and lack of awareness, these things become very significant. Regarding the patients, those who are missed or misdiagnosed or even altogether missed from the diagnosis of tuberculosis at all, uh, it's very significant risk for the healthcare and for community as a whole. For the healthcare purpose, we are missing on those patients and those who are really treatable. It's increasing the morbidity for those patients, it is increasing the mortality, and even when they get diagnosed on the later phases, their lungs or their other organs are already damaged to the extent that their future life, even after getting fully treated, it's a bit compromised. So that is a phase in which if we can diagnose a patient in the time, so we save their quality of life also. And once a patient is missed, it's a communicable illness. So once a patient is missed for a society, at the community level, it increases the risk of that person spreading the infection to whole lot of people in its vicinity, to the colleagues, to the family. In crowded cities like Delhi, if the patient is traveling by metro, he can spread it to n number of the patients, n number of the not the patients,
Other
those
commuters.
other commuters. Those finally they will become the patients again.
Correct.
So and in the healthcare setting also, which our OPDs are crowded, our hospitals are crowded. If the diagnosis of MDR is missed,
we have diagnosed the patient to be tuberculosis. We have AFB smear, and we don't know what is the resistance status. First of all, a TB patient has to be isolated. Now, if he is a resistant patient, then it's all the more a significant risk in the hospital for the healthcare workers. We are doing the procedures on them. We are doing intubations for them. We are doing respiratory procedures for them. Those are all aerosol generating. And if they are with other patients in the vicinity, they can spread the infection to them also.
Yeah, no, actually agree wholeheartedly on this, and that is where I think the and one thing which I mean, I hear from senior people like NTP director and all is that the DRTB is going to be transmitted as DRTB. It's not going to be that it is going to be sensitive and then go up the hill. So that's important. Also, the the spread is probably 1 to 15, 1 to 20. That is considered. So it's very important to break the chain of transmission, and that is where what we were talking about, the role of quick diagnostics that comes in. Yes. Thank you so much, sir. And now, Dr. Jaya, we'll the context is that MTB XDR, expert MTB XDR, has just got included in the guidelines. Um, Help is basically in quick turnaround time, as well as giving you all LPA1 and LPA2 kind of whole scenario in one in about 90 minutes with one cartridge. How What is your feedback? How can we leverage this? And not only from Max perspective, I think that leadership of Dr. Bansi already is there, but across the healthcare area.
So leveraging this test is going to be very important because we are looking at a target of stop TB in 2025, if not in 2030 at least. And I think the XDR test, the awareness in clinicians for get patients is very limited. People are still doing line probe assays and it can only be done in smear positive patients. We see lots of patients where not even a gene expert is done. You have a smear positive patient who's being treated. And when we're looking at all the regimes focusing on the resistance pattern, so which regime we choose, whether there's isoniazid monoresistance, even if you do a gene expert, you're not going to have that answer. And the treatment is different for that patient longer with another drug. That is when you see better response. So the XDR has to be available at all the government centers, apart from tertiary centers like ours, possibly even normal smaller hospitals in second tier and three tier hospitals. And doctors have to be aware that despite a gene expert positivity, we have to run that test to see IMH and other resistance patterns and then decide on a regime of treatment to get a better outcome for the patient and for society at large.
And a very, very good point, I think, which you made on smear positive only, to be sent for LPA. So smear negative, but still suspect cases might any which way will be a, what do you call that, a gap anyway. So, but thank you so much, Dr. Jaya. Dr. Garg, again, coming to you, and then we will go in the reverse order. The diagnostic criteria that you want fulfilled before you are starting the treatment, and this might be a bit of repeat, which what we have heard from Dr. Nandia already, but I guess again, it's a revision.
See, most of the things have already been covered, but the main fact is patient has to be diagnosed properly before starting with the MDR treatment. And we have got proper investigative tests, including the cultures. The traditional ones still considered to be gold standard, but again, they take a lot of time. So we have got these molecular tests now. And once see, the treatment is finally, we have gone through these, but treatment is finally designed as per the resistance of the drug and number of the drugs that those are resistant, and the other clinical features of the patient. What are their other comorbidities? What are their initial labs? So, what are their previous drug exposures, according to which we can select the regimen, and if they have neuropathies or what are their liver status, previous
Yeah,
exposures,
intervals, I mean,
QT
all.
intervals, so that we can decide the regimen. There are multiple parameters that have to be taken care of. Among them,
First one is to diagnose the TB, and second one is to diagnose the resistance pattern, and then third one to see what all previous ATT drugs has the patient been exposed to in past,
Yeah.
to make enlist them, and then to do his routine labs, then to fulfill the pre-treatment criteria of the patient, whether they have the peripheral neuropathy, whether what are their uh, ECGs, and according to that, then we start on the treatment. Diagnostic criteria, first the resistance pattern, and then the other pre-treatment evaluation of the patient. Then those have to be evaluated and started on the treatment.
It's a very, very comprehensive checklist. I think that you have to, it's not just that patient came positive, start on ATT. It's not simple like that. So, no, and also we must thank you all for being, sort of guardians of the society on this. Dr. Nair, coming back, we spoke about INH. And at that time itself, we were thinking that we'll come to the fluoroquinolone, although maybe a little less, but this is something which is also used for other patient management. So the resistance might be increasing itself. How do you see fluoroquinolone resistance? And then one is how it is impacting the BPAL-M regime and also the patient management.
Dr. Bansi very beautifully showed about the resistance. 11,000 patient
Exactly.
resistant to fluoroquine is not a small
It's
number.
not a small
honestly
number.
speaking. So, we have been advocating and requesting every one of our colleagues, please don't use fluoroquinolone in a small infection or a pneumonia or even a small, URI. You will see patient getting the fluoroquinolone just drop of the hat. And that is troubling us because when the patient unfortunately has an MDR, that we lose a very important drug. And that is what we see with the BPAL, and now because let's talk about BPAL-M because adding the moxifloxacin in along with the bedaquiline, protamid, and linezolid, it definitely enhances your treatment. It improves your treatment because moxifloxacin adding to the BPAL, it not only increases your, it turn around the improvement of the patient, the culture negativity, the time is shortened for that. It also improves, it basically the resistance to bedaquiline, the amplification of resistance to bedaquiline can be lessened with the moxifloxacin. And even after 8 weeks, you can see a lot of them getting negative, and even the recurrence rate is much less if you go with the next trial rather than the practical trial. They clearly showed that when they had three arms, the BPL, the BPLC, and the BPLM. So BPLM had a better turnaround and a better recovery in these patients. And in fact, the recurrence was hardly, whereas the other patient they still had a 4% recurrence. So adding moxifloxacin definitely helped these patients. And in case the patient is resistant, we continue on BPAL. Definitely, we continue on that. But if we can reserve our quinolones, if we can preserve them, if we can not use it in other indication, for example, I'm saying pneumonia or a respiratory tract infection, there we have better drugs to take care of it. Let's avoid using it to them, then we can definitely have a better results with the BPL-M because I'm advocating BPL-M over BPL because adding moxifloxacin definitely helps in these regimes because already these patients have come to us with the MDR. It's a last challenge to really take care of them. So we have to go all wholeheartedly in these patients. So definitely chloroquine should be prevented and should be reserved for tuberculosis only MDR as far as possible.
Very important points made here in terms of if moxifloxacin is added, then bedaquiline resistance can be lessened.
Yeah.
The treatment time is of course lesser, so better adherence by the patient. So I think it is important. It is while some trials have shown that BPAL is non-inferior to BPAL-M, but I guess still it will be better that if we can
Even the
actually
side effects were
protect
less if you go with the
BPL-M.
practical trial. They showed even the side effects with BPLM was less as compared to the BPL. So
Okay.
overall, BPLM was definitely better. If you ask me, first BPL you can say is a non-inferior, but when we have M, let's go.
Why not have that? Yes, sir. And so no, very, very. I think I'm hoping that the audience online also is registering these very, very important points that we got from Dr. Nair about why BPAL and BPAL-M. This is this very important differentiator there. Dr. Joshi, I mean, I know that you already actually, Dr. Joshi, can we, so, I know that one example you already gave wherein, the patient was misdiagnosed. Should we check it? No, no, he's there, of course. Mhm. No, you doctors actually lead a very, very busy life. That is there. I guess we'll go to Dr. Jaya first, and then check. So, ma'am, this is a this is very practical question that has come from our team, actually team on ground, field team. They are asking that are you seeing any deteriorated cases which are coming from, let's say, tier 3 towns, tier 4 towns, and what any awareness about the treatment process and the diagnostic process in these regions, is it lacking, and if something can be done? Especially the question was that if you're seeing the deteriorated cases coming in.
So I think all of us are seeing very inappropriately treated patients, patients who don't have TB, just have some lung opacity that are treated as TB. Only a smear is done and that is treated, no further testing is done. They don't look at resistance, the follow-up is poor. There was a very interesting study done in 2018, which was conducted by the World Bank with multiple collaborators over the world in two towns, Patna and Bombay, and that showed that only 35% of our patients get treatment as per the guidelines or recommendations. And that is because there's lack of awareness, lack of facilities, and we as a country have various levels of healthcare providers. We have DHMS, we have DAMS, we have MBBS doctors, we have specialists, and that gives you a very, very poor treatment at a larger level. And also, I think even us, we have all the diagnostic facilities, but it's time for us to move away from individualized practice that I see this working. We have to go for the guidelines, and for MDR or XDR TBs, we should start referring to the DOTS plus centers because we don't have the drugs available. We possibly may not be able to give the time, and the protocol that they follow is pretty good. We can support our patients through it, but it is best to refer these patients to the centers where they can get the best regime, the best drugs which are not available in the private sector.
Yeah, and ma'am, point that you are making is important, wherein I think any doctor, MBBS, even other specialties, they can give diagnosis of TB, and then perhaps can even refer the case to dot center, or can start treatment, and that probably becomes is a gap wherein either if they were aware of the complete diagnostic modalities, then it would have been a better thing. There's a lot of work to do. That is what I'll say. Dr. Bansi, now that the XDR test is there, endorsed by, recommended by WHO and NTEP, what about the ground level implementation?
We are getting a request for XDR, but we have to now more awareness and clinicians like Dr. Jaya says, still people sending line probe assays, because now after XDR maybe the line probe assay request has come down, but like a reflex testing, whenever patients sample get positive, we should immediately do XDR, the reflex testing here, because after that then sample tracing is very difficult. So whenever you get positive on MDR, like NTB positive or MDR positive, we should do the XDR simultaneously. That is more important. Now I think there is just an improvement on this XDR too. Yes.
Thanks a lot. And with this, we're coming to a close for this, panel discussion. For me, myself, I can say that I have taken so many points. I'm going to jot down so that I don't forget. Very, very good discussion. Thanks, Dr. Naya. Thanks, Dr. Jaya. Thanks, Dr. Garg. Dr. Bansi, you've always been there. Can I call, Dheeraj for felicitating? Dr. Sharad. So we'll take it on behalf of Dr. Sharad. Dr. Nair.
With this, we come to the end of our formal session. Thank you, speakers. Thank you, our eminent panelists. Thank you, Voice of Healthcare and Max Group for partnering with us for this great initiative towards eliminating TB. And we request you all for to join us for lunch. For everyone who's joined us online, thank you very much for joining us today, and thank you for all the participation and enthusiasm shown on this busy segment. Thank you.